Hello everyone and welcome to our module on breast masses. Breast masses are commonly detected by a patient through self-exam or by a clinical exam of the breast by a provider in the office. And you should be aware that breast self-exam is no longer recommended for average risk women. This used to be the recommendation, but there are a lot of false positives when average risk women do regular breast exams, so this is no longer the recommendation. And in terms of clinical medicine, the challenge of breast mass evaluation is that they may represent benign breast disease, there are many forms of this, or they could represent breast cancer, and so the workup is designed to distinguish benign breast masses from malignancy. There are a number of tools we use to evaluate a breast mass. The most definitive way to evaluate a breast mass is to do a biopsy, but unfortunately biopsy is invasive and it carries a risk of complications, so for that reason we reserve biopsy for select cases, and instead we use these other things here to try and determine whether or not a breast mass is malignant and needs to be biopsied or whether it's benign. You can get clues about the etiology of a breast mass from the clinical features, like does it change with the menstrual cycle or is there discharge, and we'll talk about some of these things later in this video. And then the two major testing modalities used to evaluate breast masses are mammography and ultrasound. A third one, breast MRI, is also available, but this is expensive and it's not covered by many insurers, so in clinical practice it's rarely used. Mammography is a form of X-ray evaluation of the breast, and the goal of mammography is to detect microcalcifications within the breast. Microcalcifications are small calcifications that can be found in the breast, and they often indicate a malignant lesion like a breast carcinoma. They are also seen in some non-malignant lesions, and later in this video we'll talk about some benign breast conditions that can cause microcalcifications. When we send asymptomatic women, meaning women without any breast symptoms or breast masses, for mammography, that's called a screening mammography. And this is the major way that we screen for breast cancer, and I talk about this in the video on breast cancer. When you're working up a breast mass or a breast lesion and you send a woman for mammography, that's called a diagnostic mammogram. And sometimes a diagnostic mammogram is followed by an ultrasound of the breast as well. This is called a targeted ultrasound, where you identify a lesion by mammogram and then you ultrasound it immediately afterwards. And this gives you information about the lesion from mammography and ultrasound all in one test to help you characterize the abnormality. When you refer a patient for a mammogram, the radiologist will interpret the mammogram using a standard system to describe any abnormalities that are present. And this system is called the BI-RADS system. BI-RADS stands for Breast Imaging Reporting and Data System. This is an American College of Radiology standard report format for mammography reports. And so the idea here is that you don't want radiologists using different language and referring providers being confused about whether or not that language is describing a significant or non-significant lesion. So instead, this standard scoring system is used so that everyone is on the same page and gets the same interpretation. So a mammogram with a BI-RADS 1 score is negative, and the follow-up for this type of mammogram is routine. A BI-RADS score of 2 means there are some benign findings, but the findings are benign, so once again the follow-up is routine. A BI-RADS score of 3 means the mammogram has findings that are probably but not definitely benign, and in this situation usually repeat imaging is done after a period of time like 3 months or 6 months or a year. A mammogram with a BI-RADS 4 finding has a suspicious abnormality, and this is usually referred for biopsy. Same for a BI-RADS score of 5, which means a mammogram that has findings highly suggestive of malignancy. This is usually referred for biopsy. And then the last category, BI-RADS 6, is used when a mammogram is performed in a woman who has a biopsy-proven malignancy. So you already know she has malignancy, but you're doing the mammogram as a follow-up test. And the higher the BI-RADS score, the higher the risk that the woman has breast carcinoma. Okay, so now that we've talked about mammography, let's talk about using breast ultrasound as part of a breast mass evaluation. So ultrasound is excellent at differentiating solid from cystic masses. And later in this video, we'll talk about simple cysts, but they're a common cause of a breast mass. They can often be drained once you identify them by ultrasound, and usually once you do this, no further workup is needed because there's a very low risk of cancer. If ultrasound identifies a solid mass, this can have benign or malignant features by ultrasound, and this can help you decide whether or not to do a biopsy. So that's a nice segue into talking about biopsies, which is the ultimate and definitive diagnostic test for a breast mass. There are several different types of biopsies used when evaluating a breast mass. A core needle biopsy obtains a core of tissue. This can be done with imaging guidance, often with ultrasound. So you locate the mass with ultrasound and then use that location to guide the needle to take a core biopsy. An alternative technique is a fine needle aspiration, or FNA. This technique only obtains cells for analysis. Its advantage over core needle biopsy is that it's a simpler procedure with less risk of complications. But the downside is you don't get tissue that you can look at under the microscope, you only get cells. So an FNA can tell you that there are cancer cells present, but it can't tell you whether the cancer is in situ or invasive. In situ cancer is contained by the basement membrane, whereas invasive disease has broken through the basement membrane. So in many cases, when you're trying to work up a breast mass and you think there might be cancer, core needle biopsy is really the preferred procedure because it gives you tissue. Fine needle aspiration is an older technique. It's been around for a long time and is still used in select cases, but it does give you less information. And then core needle biopsy and fine needle aspiration are usually done under local anesthesia. A surgical biopsy is a biopsy often done under general anesthesia in the operating room. This is usually not the initial biopsy, but you can do this when the core needle biopsy is non-diagnostic or you need a larger sample of tissue to get more information about the breast lesion. So when a woman presents with a breast mass, there are some preferred imaging modalities that you should use as your initial test to work up the breast mass. And this is high yield to know for your board, so let's talk about this now. For women under 30 years of age, the preferred initial test is an ultrasound. The reason for this is that before age 30, the breasts are very dense and mammography is very difficult to perform. In addition, before age 30, there's a very high likelihood of a breast cyst being the cause of the mass, and breast cysts are easy to identify by ultrasound. So before age 30, ultrasound is the preferred test, and if it's a simple cyst, which we'll talk about later, the options for treatment are drainage or observation. If, on the other hand, it's a complex cyst, then usually the woman is referred for biopsy. Non-cystic lesions by ultrasound can be followed by mammogram in some cases, but remember, mammography is difficult in younger women, or the lesion can be referred for a biopsy. When women are over 40 years of age, in this age group, breast cancer is more likely and mammogram is a more helpful test, so mammography is the test of choice in this age group. If the woman has a low BI-RAD score from her mammogram, then you can do an ultrasound because she could have a cyst. If she has a high BI-RAD score, then she should be referred for biopsy or excision. And then women ages 30 to 39 are an intermediate group. In this age group, either modality, ultrasound or mammography, is acceptable for workup of a breast mass. So when a woman has a breast mass or a finding on mammography like microcalcifications, we call that a breast lesion. And if you do a biopsy, you can basically think of the potential results as falling into one of three categories. You could find carcinoma or carcinoma in situ, and I talk about these things in the video on breast cancer. But there are also a large number of benign conditions you can find called benign breast disease. And so for the rest of this video, I'm going to talk about some of these benign breast conditions that can lead to breast lesions and that you can discover through a biopsy. And then you should also be aware that in actual practice, we don't always do the biopsy to diagnose benign breast disease. Sometimes we do an ultrasound, and if it appears to be, for example, a cyst or some other benign condition, we often assume the woman has benign breast disease without doing the biopsy. So benign breast lesions are classified histologically based on their appearance under the microscope after a biopsy into three categories. The first is non-proliferative lesions, the second group are proliferative lesions without atypia, and the third group is atypical hyperplasia. All of these are benign, meaning they don't represent cancer, but some of them are associated with an increased risk of subsequent breast cancer. So what that means is even though the lesion itself isn't malignant, it indicates that the woman has a higher risk of developing breast cancer in the future, and that often leads to more intense monitoring or sometimes interventions for prevention of breast cancer. The first group of benign breast lesions we'll talk about are the non-proliferative breast lesions. And a number of these lesions are just simply called fibrocystic breast changes. This refers to a group of breast changes or lesions that are not associated with an increased risk of cancer. Fibrocystic breast changes usually occur in premenopausal women, and these women will present with lumpy, bumpy breasts. And the concern here is that it could be breast cancer, and you need to distinguish these benign fibrocystic breast changes from breast cancer. Fibrocystic breast changes may cause breast pain. This is called mastalgia, and often the pain is cyclical and it gets worse the week or so prior to menses. And when women have mastalgia from fibrocystic breast changes, this is often improved by combined oral contraceptive pills, And so one of the many benefits of using these pills for contraception is that they can improve mastalgia. Besides fibrocystic changes, there are a number of other non-proliferative breast lesions, and I've listed the important ones on this slide. Just like fibrocystic changes, none of the conditions on this slide are malignant, they're all benign, and none of these are associated with an increased risk of breast cancer. This means that if you discover one of the lesions on this slide in a woman with a breast lesion, her risk of breast cancer has not increased because she has one of these things present. Simple cysts are the most common form of non-proliferative breast lesion, and we'll talk about this in the next few slides. But then these other items listed here are also considered non-proliferative breast disease. I won't talk about these in detail, you can read about them, but they're all non-proliferative, they're all benign, and not associated with an increased risk of breast cancer. So let's talk about breast cysts in a little more detail. Breast cysts are a common cause of a breast mass, and they're easy to identify by ultrasound, and using ultrasound you can categorize breast cysts as either simple, complex, or complicated. A simple breast cyst has smooth, thin walls and it's completely filled with fluid, which makes the center of the cyst dark black by ultrasound. This is an example of a simple breast cyst on the bottom left side of the screen here. Notice that the walls are thin and it's completely filled with dark fluid. Notice also that the posterior or back wall is bright white compared with the anterior or front wall. You can see this bright white color to the back wall of the cyst. That's called posterior acoustic enhancement, and this is a classic feature of simple breast cysts. This is a finding anytime you have a fluid-filled cavity and you analyze it with ultrasound, the back wall will be brighter when there's fluid inside the cavity. Complex cysts have irregular borders and thick walls, and they have solid areas or debris inside the cyst. This is an example of a complex cyst over here on the right. And then a complicated cyst is an intermediate category. It has some low-level internal echoes. It's not completely black in the middle, but it still has some features that resemble a simple cyst. Simple breast cysts can be detected on exam as smooth, firm masses. Sometimes they can be tender. Importantly, the physical exam cannot distinguish a simple cyst from malignancy, so just because it feels like a simple cyst doesn't necessarily mean it can't be a malignancy. By ultrasound, simple cysts have all the features we talked about on the last slide. They're well circumscribed, they have anechoic or black fluid in the center, and they demonstrate posterior enhancement. And if you do a mammogram to work up a simple breast cyst, this is not required, but if you do order one, the mammogram will be interpreted as BI-RADS 2, indicating only benign findings. In terms of management, if you identify a simple breast cyst and the woman is asymptomatic, meaning she has no tenderness and there's no distortion to the breast from the cyst, then you don't have to do any further workup. Keep in mind though, this only applies to simple breast cysts. Non-simple cysts like complicated or complex cysts may require additional workup to exclude malignancy. If the cyst is symptomatic, either because it's tender or it's distorting the contour of the breast, then you can treat the cyst with fine needle aspiration. This drains the fluid from the cyst and should resolve it. Usually the aspiration yields clear yellow fluid, although sometimes it's green or bloody, and when this happens the cyst is still usually benign and this doesn't indicate malignancy. And then you should know that cysts can recur after aspiration, so usually women return for a follow-up exam in 2 to 4 months to make sure that the cyst is still resolved after aspiration. So back to this slide on benign breast lesions. Now we've talked about non-proliferative lesions, including fibrocystic changes and simple breast cysts. We're going to move on now and talk about a different group of benign breast lesions. Those are the proliferative lesions without atypia. So in a proliferative breast lesion without atypia, there's a proliferation of breast tissue cells, but there are no atypical cells, meaning all the cells appear normal. And the thing to know about these lesions is that they've all been associated with a small increase in the risk of subsequently developing breast cancer. So even though all these lesions shown on this slide are benign, once a woman has been diagnosed with one of these lesions, her risk of subsequent breast cancer is slightly increased. And there are many subtypes of proliferative lesions without atypia. We'll talk about fibroadenoma and intraductal papilloma in this video. I won't talk about epithelial hyperplasia or sclerosing adenosis, but you can read about these. They are both additional examples of proliferative breast lesions without atypia. So a fibroadenoma is the most common benign breast tumor. It's a mass of fibrous and glandular tissue, and histologically it's very similar to fibroids in the uterus. And in fact, women who have fibroadenoma of the breast often have uterine fibroids as well. Fibroadenomas occur in premenopausal women, also just like uterine fibroids do, And also, like uterine fibroids, they are hormone sensitive. They increase in size during the menstrual cycle and pregnancy, and they decrease in size after menopause. And fibroadenomas present as a well-defined solid mobile mass in the breast. In terms of workup and management, if you suspect a fibroadenoma in an adult, you can usually make the diagnosis by ultrasound. Fibroadenomas have a classic appearance by ultrasound. They appear as a hypoechoic, meaning a gray mass. This is a picture of what one looks like on the screen here. And so in many cases, if the mass has a classic appearance of a fibroadenoma and classic findings by ultrasound, that's enough to make the diagnosis in an adult. You can do a core needle biopsy if the diagnosis is unclear. This can easily be done using ultrasound guidance. And remember that these lesions are benign, so once you identify one, either through biopsy or classic ultrasound findings, you can follow the lesion clinically and it doesn't require excision. Adolescents are sort of a special case when it comes to fibroadenomas. Breast carcinoma is incredibly rare in adolescents, and fibroadenomas are the most common breast mass. So in this group, fibroadenomas can sometimes be diagnosed clinically alone without an ultrasound. So for example, if a teenager presents with a well-defined solid mobile mass, the mass has premenstrual tenderness and it shrinks in size after menses, all of these are classic features for a fibroadenoma, and so in an adolescent you can make the diagnosis based on these clinical features. For equivocal cases, ultrasound can be used, or FNA or core needle biopsy. And then just like in adults, these are benign lesions. They don't have to be excised, and in most cases they are simply left alone. Intraductal papillomas are another example of a benign breast tumor. The thing you always want to remember about intraductal papillomas is that they're the classic cause of unilateral bloody nipple discharge. Papillomas are associated with a small mass, but often it's not palpable, so the only clinical feature may be bloody nipple discharge. These lesions are caused by a growth of normal ductal epithelial cells, and the cells grow in finger-like projections. That's why it's called a papilloma. In any woman that has these, you have to exclude malignancy, because malignancy can also present with bloody nipple discharge. So usually the workup involves mammography and ultrasound, and these are diagnosed with a core needle biopsy, and in most cases they're surgically excised. So that's a nice segue into a brief discussion of nipple discharge. So when a woman presents for evaluation of nipple discharge, you need to determine whether it's physiologic discharge or pathologic discharge. Physiologic discharge is usually bilateral, and the discharge is usually clear or milky. So when these features are present consistent with physiologic discharge, usually the workup does not involve imaging or testing of the breast. Instead, it usually involves blood tests, and that's because physiologic discharge is usually due to hyperprolactinemia. So the testing that's usually done is a pregnancy test, some kind of HCG test. That's because pregnancy raises prolactin levels. Also a serum prolactin level, and also a TSH, because thyroid disease can alter prolactin levels. And then beyond these things, if a woman has an isolated elevation of prolactin level, a pituitary MRI is often done because a pituitary adenoma is a potential cause. Pathologic discharge is discharge that's unilateral, it can be bloody or serous, and it can be associated with a breast mass. And so anytime these features are present, there's a possible malignancy, and the workup is going to involve imaging and testing of the breast. So usually the workup involves a mammogram or an ultrasound similar to the workup of a breast mass, and the most common cause is what we talked about in the last slide, intraductal papilloma. So let's go back once more to our list of benign breast lesions. We've talked about non-proliferative lesions, and now we've talked about proliferative lesions without atypia, like a fibroadenoma. Let's now move ahead and talk about the last category, which is atypical hyperplasia. So there are two types of atypical hyperplasia, atypical ductal hyperplasia and atypical lobular hyperplasia. Usually atypical hyperplasia is an incidental finding when a biopsy is done for other reasons. Atypical hyperplasia doesn't often produce a mass or abnormalities on mammography. But what you need to know about this benign breast lesion is that even though it's benign and doesn't represent a cancer, women who have atypical hyperplasia have a substantial increase in their risk of developing subsequent breast carcinoma. So if a woman develops a breast mass or an abnormal mammogram finding and she goes for biopsy and the biopsy identifies atypical hyperplasia, then that woman is at significantly increased risk of developing breast cancer. And in many cases, risk reduction strategies are done for women in this situation. They often get annual mammograms and twice yearly breast exams, and then you want to remove any sources of hormones that could drive growth of breast cancer, so these women should stop oral contraceptives and avoid hormone replacement therapy. And in some cases, drugs like selective estrogen receptor modulators or aromatase inhibitors are used to decrease the amount of estrogen that is in the body that could drive growth of a breast cancer. Another high-yield thing to know about atypical hyperplasia is that once it's identified by core needle biopsy, that is usually followed by a surgical excisional biopsy to remove more tissue. The reason this is done is that when atypical hyperplasia is present, there's the possibility of an associated higher grade lesion that was missed by the core needle biopsy. So by following the core needle biopsy with a surgical excision biopsy, you can exclude another high-grade lesion, and up to 30% of cases of atypical hyperplasia will be upgraded, meaning the surgical excisional biopsy will find a higher grade lesion like carcinoma in situ or even carcinoma. And so now I'll finish this video by talking about a couple of special breast lesions that have unique characteristics. These sometimes come up on board exams, so it's good if you've heard of them. We'll start by talking about a phylloides tumor. This is a stromal breast tumor. The word phylloides is the Greek word for leaf-like, and it gets its name because this tumor involves leaf-like growths of stroma. Usually these are benign. Low-grade forms are similar to fibroadenomas, which are also stromal breast tumors, but high-grade variants of phylloides tumors can metastasize. These tumors present as a growing mass, and they usually occur in older women greater than 60 years, and so this differentiates them from fibroadenomas, which are stromal tumors that usually occur in premenopausal women. A phylloides tumor usually occurs in an older woman. These can be diagnosed through ultrasound and core needle biopsy. They have a characteristic appearance by ultrasound. This is shown on the screen. You can see that it's a mass with all these growths in the center of the mass. And usually it's treated with surgical excision because it can have high-grade portions of the mass which can become metastatic. Fat necrosis is a benign inflammatory breast process that results from trauma. Often the trauma is a prior breast biopsy or breast surgery, but it can also be things like a sports injury or a seatbelt injury. Many women who are diagnosed with fat necrosis do not recall a specific trauma in the past. The reason fat necrosis is important clinically is because it often mimics breast cancer. It can present as a painless mass in the breast, and it may cause calcifications on mammogram, which will raise concern for malignancy, but then when you do a biopsy, you don't see carcinoma. Instead, you find fat necrosis with inflammatory cells. And so once this is identified at biopsy and you know that the woman has fat necrosis, no further treatment is indicated because, as I said, it's a benign process. And then I'll finish this video by mentioning a galactocele, which is a milk retention cyst. These often develop in women who are breastfeeding. They develop obstructed milk ducts, and that leads to formation of a cyst containing breast milk. On ultrasound, galactoceles usually appear as a complex cyst, like what's shown on the screen here. And if you do a fine needle aspiration, you will see a milky substance. That's because these cysts contain breast milk. There's no specific treatment required, and this is not associated with an increased risk of breast cancer. It's a benign lesion caused by retention of milk. And that concludes our module on breast masses.